Myself, Dr. Dhiraj Kumar Panda from Bhubaneswar. Today, we are going to discuss about a case, a 57-year-old man with type 2 diabetes, hypertension, microalbuminuria. The patient visited clinic, complained with weakness for past 2 months, routine checkup, she find weakness, hospitalized for SCS for cardiac disease 1 year ago. Presently, he was taking metformin 1 gram BD, glimepiride 4 milligram OD, losartan 50 milligram OD, atorvastatin 40 milligram OD, amlodipine, chlorothalidone, and metoprolol. So all things has been given. On laboratory finding, we found that HbA1c is 8.2, not controlled. eGFR is 88, which is low. LDL is that lipid parameter is controlled. Urea creatinine is 1.1 milligram. Physical examination, BMI is 31, little bit obese, and PP 120/70, and heart rate. So for this patient, optimizing glycemic control with cardio and renal protection are the primary treatment consideration. An A1C goal for many non-pregnant adults is still less than 7 by ADA, is appropriate. On the basis of provider judgment and patient preference, achievement of lower A1C such as less than 6.5 may be acceptable if this can be achieved safely without significant hypo or other adverse effects. A better management during the last 2 decades allowed reducing the incidence of CV complications, yet the residual risk remains high in patients with type 2 diabetic mellitus. CKD remains a concern, at least partly due to the reduction premature death among type 2 diabetic patients. Renal disorders are common in type 2 diabetics, with approximately 50% of patients developing some degree of renal impairment and an increasing prevalence of both conditions over time. The risk of renal disorder in type 2 diabetic includes the development of multiple phenotypes of organ damage, often overlapping and ultimately progressing similar to what occurs for cardiovascular disease. So EMPA-REG outcome was a randomized, double-blind, placebo-controlled phase 3 trial involving more than 7,000 people with type 2 diabetes, almost all with established CVD. The mean eGFR at baseline was 74.1 milliliter per minute per 1.73 meter square body surface area, and the median urinary albumin creatine ratio was 18 milligram per gram. So, pre-specified renal outcome in this study includes incident or worsening nephropathy defined as progression to macroalbuminuria, doubling of serum creatinine associated with eGFR. So, a main drive for education in nephropathy with EMPA was a lower progression to macroalbuminuria compared with placebo. EMPA was also associated with significant improvement in a host composite endpoint, incidence of worsening nephropathy or CV death, progression to macroalbuminuria. Initiation of therapy, that is heart HR 0.9 and 95% confidence interval, with no difference reported between the 2 therapeutic doses. So, the inhibition of SGLT2 leads to tubuloglomerular feedback via enhanced natriuresis and delivery of sodium to the macula densa, thereby decreasing diabetic glomerular hyperfiltration due to hyperglycemia. This is hypothesized to reduce the resulting chronic kidney damage. Ketone bodies are a more energy efficient fuel in renal tubular cells than glucose, and so renal oxygen consumption is reduced in the presence of mild ketosis. Hence, it has been suggested that the use of ketone bodies as energy substrate in patients receiving SGLT2 inhibitor may contribute to the renoprotective effect of these agents with a similar mechanism as in the myocardium. Now come to DPP4 inhibitors reportedly ameliorated renal function and pathology in TKD. Linagliptin decreased podocyte apoptosis, one feature of CKD pathology, by enhancing insulin signaling. The Carmelina study, which is linagliptin versus CV outcome study, confirmed that Lina reduced the progression of albuminuria by 14%, reduced risk of progression to albuminuria. Moreover, linagliptin demonstrated CV safety, including in patients with advanced CKD. Linagliptin slowed progression of albuminuria without affecting eGFR slope or other kidney outcomes. So there is strong rationale for combining this DPP4 inhibitor and CV protective class of SGLT2 inhibitor in a patient with type 2 diabetic mellitus, because two drugs exert different and complementary glucose lowering effect. Furthermore, the increase of glucagon level induced by SGLT2 inhibitor may be blunt by the co-administration of DPP4 inhibitor. Clinical evidence shows that SGLT2 DPP4 combination is an effective option for management of type 2 diabetic mellitus, providing HbA1c reduction of 1.1% to 1.5% and weight reduction of approximately 2 kg when added to metformin, which is primary place of therapy. In phase 3 randomized trial investigating efficacy and safety of EMPA and LINA, better tolerability was observed in subjects who have EMPA LINA 25/5 than those alone EMPA in terms of serious adverse effects like hypogenitalia infections. This fact implies that EMPA LINA add-on to metformin constitute equal or even better tolerability than monotherapy with additive glycemic efficacy in uncontrolled patients. This unique combination lends itself readily to early treatment intensification because of good glycemic control and tolerability, possibly weight loss also, and CV protection and minimal treatment burden, and offers the renal protection in patients with type 2 diabetics who are at high risk of CVD. So that's why this combination fares better in early treatment of type 2 diabetic patient for better cardio and renal protection. Thank you.